Bangalore. Thank you, Chandrasekhar, Vinita ma'am, Sabhan, Nirupa ma'am. I come from the land of Gandhi. Gandhi glorified poverty, so I will speak on poor man's biologics, steroids, which is the mainstay, and my talk will be biased by the bias that a practitioner has, because I'm not an academician, I'm not in any way linked to any hospital, any medical training program. And I have included all my references in the article that I have sent in the souvenir, so I won't be including the references here. And so my talk will be what an average rheumatologist in practice does, kind of a balance of things, and try to add a little bit of evidence here and there, which I've given there. So, but I'll try my best to justify the topic that I've been given. September 21st, 1948 was the date when Philip Hench, as all of you know, the person who discovered steroids, injected 3 shots of hydrocortisone to a lady crippled with rheumatoid arthritis for years. And the effect was miraculous. She started walking. We had the chance of looking at the video in one of the conferences in Mumbai. I don't know if the conference was probably President Chandrasekhar. And we saw the video, and it would not be unusual to look at it now, but then it was really a magic drug for people who saw that. And that initial gave way to a lot of the use of that drug subsequently for a few years, and then the side effects started appearing, pushing over faces and other things, to the extent that, as many of you know, Philip Hench actually committed suicide when he came to know about the side effects of these drugs. And there was a period when steroids were looked at as, many of us still look at it now as, you know, as something that should not be given, and many times you try it and goes to other doctor and says, "Nahi dena hai," kind of thing. And very recently, in the last 10 years, there has been a resurgence of the use of steroids in the right way, used by the right doctor, in the right way, in the correct doses, correct duration. And that is what I'll try and do in the next half an hour, how it should be used. The dose of, coming to the general principles of treatment, the doses of steroids vary according to the condition that you are giving, and according to the amount of inflammation that is present when you're giving it to the patient. For example, a patient of lupus nephritis, class 3 or 4, which is proliferative nephritis, you need to really bombard these patients, especially if they are early in disease. There's not much of damage. You need to give 1 milligram per kg. So the weight of the patient is 50. You give 50 milligrams for 4 to 6 weeks. That is the duration you give, and then start reducing at least 4 to 6 weeks, or some of us may even give it for 6 to 8 weeks. So that is the importance of dose and the duration of treatment. As against rheumatoid arthritis, an aggressive disease, for the joints, 7.5 10 milligrams would probably suffice as a bridge therapy till the disease modifying starts working. You could also debulk with high doses and come down to lower, like in the COBRA regime. I'll be coming to that. So the doses are very important, the duration of treatment, as I said, and then continuing it for years or continuing for months and then taking it off, that is still a matter of debate. Coming to the synthetic analogs, which the company fellows constantly come and tell you, you will always get confused, and we are also asked these questions. Sometimes we don't know the answers, we still don't know very honestly. But when I was asked repeatedly about these questions, I looked at it myself, especially about deflazacort, which is a new drug which has come in the market and is used left and right by many people, and I also sometimes do use it. But there is little evidence to support that one synthetic analog is actually superior to another, and they are all equal in terms of efficacy. Some studies would suggest that simple prednisone is better, some studies say that deflazacort might have lesser side effects, and I saw that in children there was more use of deflazacort for some reason, probably because of the bone sparing effects, a little bit of it. But in short, these synthetic analogs, the kind of responses that they've had in vitro studies have not really translated that much into in vivo. So it's a matter of choice, and for the same reason as one would probably buy a Bajaj scooter or a Maruti because of long-term use, one would use simple prednisolone because the absorption there is more dependable. Steroid sparing immunosuppressives we tend to use as rheumatologists whenever you feel that the dose of steroids, a high dose, is going to be required for a long time. Then you obviously add something like azathioprine or mycophenolate or cyclophosphamide so that you can reduce the drug. These are known as steroid sparing immunosuppressives. All of you are aware of the adverse effects of steroids, and just 1 or 2 things about corticosteroid induced osteoporosis. It is that osteoporosis, bone loss from steroids, starts with the very first day that you start prescribing it. 7.5 to 10 milligrams of prednisolone is known to cause some amount of bone loss. So it starts with the very first dose, and that is why the need for giving calcium and vitamin D supplements to these patients. Avascular necrosis can occur with a single dose of 2 milligram per kg of methylprednisolone in the patient that it is to occur. So obviously there are other reasons why some patients get avascular necrosis. We have not been able to decipher those as yet. Atherosclerosis, the long-term complication of steroids, it adds to coronary artery disease, and well, that's a double-edged sword, because in rheumatoid arthritis, where you have long-term inflammation, inflammation itself is known to cause atherosclerosis and disease damage on the one hand, and steroids there would actually prevent it. But in the long run, steroids themselves would also probably lead to this kind of a problem. So you have to really balance these things. And so the need to supplement, as I said, calcium and vitamin D in all patients who are on steroids. And the American College of Rheumatology has recommended giving bisphosphonates to patients where you would contemplate giving more than 10 milligrams of prednisolone for more than 3 months, especially in postmenopausal females. In premenopausal females, it would be guided by the BMD done by DIGSA, of course, but that is a recommendation by the ACR. Coming to the individual diseases, I'll just cover some of them. Rheumatoid arthritis in early disease, as was pointed out by Vinita ma'am in the previous talk, and by Chandrasekhar also, that in early disease definitely it is known to prevent erosions. There is sufficient evidence to support that now, and so many of us would probably use steroids in the initial if the patient is early in disease. Normally we tend to use it as what we call as a bridge therapy till the disease modifying drug starts acting. So when you give methotrexate and there is an aggressive disease early, the patient is early in disease, you tend to combine with low dose of prednisolone and then take it off in 3 or 6 months. By that time methotrexate would have its effect. That is known as bridge therapy. That is the most commonly used form of therapy that we tend to use. The extra-articular complications of rheumatoid arthritis, especially in long-term rheumatoids, the patient comes to you 5 to 7 years of disease, 10 years of disease, the joints are already deformed. In fact, there is not much of joint pain. And you actually look at the extra-articular complications, which means secondary Sjogren's, interstitial lung disease, rheumatoid vasculitis, amyloidosis, and those kind of complications. And extra-articular disease, of course, steroids would still be the mainstay of treatment. Of course, now there are biologics and some studies to support. But as I said that in our country, most patients would not afford biologics, and so we still resort to steroids in these complications. The landmark studies of people have used, there are a lot of other studies, but some of them which have been very famous, steroids have been used in the COBRA study, which was published in 2002, and the recent update which had come a couple of years back had convincingly shown in that they use a debulking dose of steroids, a high dose of steroids, and then bringing it down quickly over, and then comparing it with a single drug, the combination therapy with prednisolone versus single drug like sulfasalazine, and they found that the combination regime was far superior to the single one, especially in terms of radiological outcome. The best study, which was published in 2005 in arthritis rheumatism, again showed there were 4 arms, and in that one was prednisolone, the other was infliximab with methotrexate, and the other 2 were monotherapy, sequential, and combination therapy. And again there they found that both infliximab and prednisolone arms did better than the other 2 arms. So, and it becomes very relevant in our country because steroids are the mainstay of treatment, and we can use them in patients where they cannot afford biologics. The Cochrane review in 2007 convincingly, which is one of the most authentic data, that corticosteroids are indeed disease modifying drugs and that they do prevent radiological outcome if used early in rheumatoid arthritis. So that is one of the most convincing evidences for the use of steroids early in disease to prevent erosions. That is a rheumatoid vasculitis ulcer. You take a biopsy from here to confirm fibrinoid necrosis and vasculitis, and these are the patients who would require high doses of steroids initially combined with cyclophosphamide or azathioprine, and then maintaining to a low dose, which sometimes needs to be continued for a long time. These are the extra-articular complications of rheumatoid, long-term rheumatoid arthritis. That is the COBRA regime, where this was the combination arm and this is the single arm, and as you see that the radiological score is more in the single arm than the combination arm. Of course, what this slide shows is that we still need better efficacy to ensure that this comes down further, and that would be by the early use of prednisone here or the early use of biologics in necessary cases. You can bring this graph down even further. This is taken from my textbook of rheumatology, the hospital textbook, and just to speak a little about juvenile rheumatoid arthritis. Again, steroids are a double-edged sword here because in cases of systemic onset juvenile idiopathic arthritis, also known as Still's disease, where these children come with high fevers and neutrophilic leukocytosis and joint pains, you have to use steroids in most of these patients combined with other disease modifying drugs. Many of these children, as you will see in practice, would require low dose of steroids for a long time, and only then they actually, as against that, in the misuse or the abuse of steroids in patients, in children who have just 1 or 2 joints, intraarticular steroids are fine, but systemic steroids are not needed in these children, and that leads to growth retardation in children, especially the growing age. This is just to show how much the height difference between a child with rheumatoid, juvenile rheumatoid, as against a normal adult of that age, to show how crippling the disease can really be in children. Coming to spondyloarthritis, these are more often diagnosis in young males. They come with lower limb joints, and ankylosing spondylitis, of course, being the most severe form of that. There is no real evidence for the use of steroids in the axial disease of ankylosing spondylitis. There are some early trials that people are trying methylprednisolone boluses and those kind of things, but there is no real hardcore data to support the use of steroids in axial disease of ankylosing spondylitis. The only drugs that are known to work are NSAIDs, and that is what is recommended, continuous NSAIDs for years, or biologics is the other one. If you don't respond to 2 NSAIDs, the ACR recommends using 2 NSAIDs and then going on to biologics. The sacroiliac joints, where you use steroids in axial spondyloarthritis is sometimes in refractory sacroiliac joints. Since in our country biologics are really very costly, you have to sometimes inject the joint, the sacroiliac joint, with the local steroid under fluoroscopic guidance. Peripheral arthritis, if there is a lot of peripheral arthritis, spondyloarthritis, like an inflammatory bowel disease, for example, you have, then of course you use steroids to just control that till the disease modifying drug acts. Intraarticular steroids are very useful. Sometimes refractory enthesial sites. Enthesis is where the fascia ligament or the muscle binds to the bone, like the Achilles tendon, and sometimes you have to inject intra-enthesial joints. In psoriatic arthritis, sometimes as a bridge therapy till the disease modifying drug starts acting. In uveitis, a complication seen not very uncommonly with anti-uveitis seen in ankylosing spondylitis, of course, these patients sometimes do need oral steroids. And long-term complication of ankylosing spondylitis, not very often seen, but again there you would require other drugs. That is sacroiliitis of both the joints, and sometimes these are the joints which need to be injected if these patients don't respond. Not very often actually, I've hardly done it in practice, but that is something that you could do if these patients can't afford biologics. Coming to lupus or the connective tissue diseases, well, lupus we mainly divide into a major organ lupus or a minor organ lupus, or what we call as the organ threatening lupus or a non-organ. In minor organ lupus, which means where you have just hair fall and skin rash and joint pains, you might not always give steroids. There is a common misconception sometimes that the moment you see an ANA positivity and joint pains, and one tends to start steroids, but that may not be necessary all the times. Minor organ lupus responds very well to antimalarials, and antimalarials are actually the first drug that we would give in hydroxychloroquine, especially in lupus. You start on the day 1. It is known to prevent major organ involvement, and so along with that you would combine NSAIDs and try out to control the joint pains. But yes, most of these patients, I agree, in practice do require low dose of to control the joint pains and the other symptoms, but you could try it without the joint pains. As against organ threatening lupus, like in lupus nephritis, these steroids are a must, and you have to use them according to what class nephritis the patient belongs to. And even in neuropsychiatric lupus, CNS lupus, especially if it's a CNS vasculitis, it's actually not so common with lupus, but there you have to use steroids. As against chronic, it is known as chronic OBS or chronic organic brain syndrome, which is actually like you see in rheumatoid arthritis, damage which is left there. Sometimes you have this damage which is permanent in the brain, and then there is no point in using steroids or in these patients. So these are kind of burnt out neuropsychiatric cases, and there you just resort to psychiatric drugs to control the disease. But differentiating that is sometimes very difficult, but you have to do that before embarking upon such heavy drugs for a long time. There have been studies where people have shown that lupus patients are somehow more vulnerable to avascular necrosis, and one particular study looked at reported that the SLEDAI, which is the disease activity score, was more in these patients who reported AVN, and some of these patients had more cholesterol levels than lipid levels than. There were also some couple of studies in antiphospholipid, but we really don't know the cause, but somehow they are more vulnerable to AVN than the other patients, other rheumatology patients. IV methylprednisolone boluses in a monthly, this is also a regime frequently used, especially in the United Kingdom, where they combine it with cyclophosphamide pulses in the hope of reducing the side effects of steroids. But sometimes you just have to give daily steroids to control the disease. Oral dexamethasone boluses are mainly used for refractory ITP, and I think all of you are aware of that as physicians. There are some studies where they've used oral dexamethasone boluses to control ITP, even as a part of lupus, thrombocytopenia. And dexamethasone for complete heart block in patients who have anti-Ro antibody positive to prevent in a neonatal lupus, which is on the neonatal lupus, to prevent, one has to use dexamethasone if the child in utero is getting bradycardia. That is avascular necrosis report in the case of lupus. Now coming to scleroderma and the mixed connective tissue disease disorders, there have been ample studies in trying to, as you all of you know, scleroderma is one of the most frustrating diseases that we treat, and even for rheumatologists, for the patient and for the doctor as well, because we really don't have anything in scleroderma that works. And so people have tried in the initial inflammatory phase of scleroderma, where there is a lot of puffiness, and then they go on into skin thickening. So in the stage of puffiness with a lot of, we believe there is a lot of inflammation, people have tried lots of steroids, immunosuppressives, and even rituximab recently has been tried. But most of the studies as regards steroids have really not shown convincing evidence of its use in scleroderma. Having said that, I would want even Vinita ma'am's and Dr. Chandrasekhar's and Dr. Dharman's view. When we use steroids in patients with interstitial lung disease with scleroderma and all, these patients do report some improvement in skin thickening. Maybe it's a subjective feeling, but they do report. But there is no hardcore evidence for the use of steroids in scleroderma skin disease. Many dermatologists would probably differ, and they tend to use dexabolus regimes and those kind of things. I have not found real evidence of use of that. So, but I think the conclusion is that one should avoid using it for skin disease, especially in diffuse scleroderma, which is the scleroderma which affects the entire body, including the abdomen, the chest. It could actually precipitate a scleroderma renal crisis, and it has been known to which causes accelerated hypertension and a rise in creatinine. In pulmonary hypertension, again the same story. People have tried a lot of immunosuppressives in pulmonary hypertension. This regime is being tried out of frustration because we don't have, now we have drugs like bosentan and other sildenafil which are being used, but there is again not real hardcore evidence to support the use of immunosuppressives in pulmonary hypertension resulting in scleroderma. Interstitial lung disease, again the problem there is, while steroids are recommended and are being used for the non-specific interstitial pneumonitis reported with scleroderma, the problem is that in scleroderma, especially Siebold, one of the workers in scleroderma, had very convincingly shown that the ILD of scleroderma doesn't necessarily progress. It might just halt on its own at a particular level, and so we give steroids and we feel better, but it is possible that these patients would have actually halted on their own. So sometimes it is very important to, so you keep doing repeated PFTs, and if the patient has an increase in her symptoms and her problems or the HRCT, then of course one would use steroids. We do use steroids in most of our patients of ILD of scleroderma. Polymyositis scleroderma overlap is a problem that I not infrequently encounter, and there again for polymyositis part, one would tend to use steroids with steroid sparing drugs in these patients. Vasculitis is a rare complication of scleroderma, but is seen like non-healing ulcers, gangrene, not the occlusive gangrene, but the vasculitic gangrene. And there, of course, one has to be, one has to take that judgment that whether to give steroids or not, backed by histopathological proof of vasculitis, of course. Inflammatory myositis is a disease which does require steroids most of the time, but of course it would depend on what duration of illness the patient has had before he or she presents to you, because sometimes these patients present very late in disease, months or even years after their disease, when most of the damage has actually been done. They have contractures, and at that point of time there is no real benefit in bombarding with high dose of steroids. They just require good physiotherapy and various kind of prosthesis. But patients who are early in disease, of course, and have a lot of inflammation, especially in cases of juvenile dermatomyositis, which is actually a vasculitis, you would require high doses of up to 2 milligram per kilogram to control the inflammation. As I said, for an adequate duration like 4 to 6 weeks, and then start coming down, tapering them. Sometimes these patients, especially those with the pharyngeal involvement, do require even IV methylprednisolone to really control the disease or even IV gamma globulin. Interstitial lung disease of myositis, especially amyopathic dermatomyositis known as AMD, where you don't have real clinical myositis, muscle weakness, but you have the skin rashes of dermatomyositis. These patients peculiarly get more of interstitial lung disease, and that ILD is sometimes really very bad and doesn't respond to any kind of medicines. I've lost a couple of patients, and that is known in the reported literature that many of patients die, and people have resorted to various kinds of regimes like steroids and cyclosporin and cyclophosphamide, and sometimes these patients just don't respond. So that is one area where we use steroids. Calcinosis cutis is a long-term complication of dermatomyositis, and there was one recently very good article on Medscape on dermatomyositis, very good review, and then they said that the only way to control calcinosis cutis is treating the disease earlier on very well, so that it doesn't come out as a long-term complication. Otherwise, sometimes really nothing works. We've tried various regimes like diltiazem and warfarin, those drugs, but steroids don't have a very convincing role in calcinosis cutis. This is calcinosis cutis. These are calcification spots in the patient of dermatomyositis. Now coming to the vasculitic disorders, small vessel vasculitis like henoz-corneal purpura and leukocytoclastic vasculitis, most of these patients would not require any kind of treatment. They just have to be told that this is a disorder which will, especially HSP, will resolve on its own, and you just have to keep monitoring the urine to look at the complications in those 5 to 10% of cases where you would have, and they would not require steroids, most of these. Organ threatening vasculitis, for example, axonal neuropathy, when you get like an organ threatening lupus, of course these have to be controlled with steroids immediately to prevent wrist drop or foot drop, especially mononeuritis. You have to act early and fast and with sufficient doses of steroids to control that process. The ANCA-associated vasculitis, which are the Wegener's granulomatosis, Schurg-Strauss, and microscopic polyangiitis, most of these, or probably all of these, would require steroids to control the disease. And then you could use steroid-sparing drugs like methotrexate or cyclophosphamide later on and bring down the dose of steroids. And they are notorious in relapsing, especially Wegener's. Of course, now there are biologics. Rituximab is also being tried, but these are for refractory cases of Wegener's. Coming to giant cell arthritis, would require higher doses to control the ocular inflammation, because otherwise you would have blindness. Takayasu's arthritis, peculiarly seen in our country more often. Again, you require steroids in these patients. Most of these would require, along with a steroid-sparing drug like methotrexate or cyclophosphamide, or mycophenolate is now used in Takayasu, and you would bring down the dose of steroids to a lower maintenance dose, which then has to be continued for at least a couple of years. CNS vasculitis, a thing which is not very often seen or picked up or maybe missed, I don't know, but again, theoretically, most of these cases would require steroids, except for the benign angiopathy seen. There is a benign angiopathy of CNS seen, especially in young women, and they get this CNS vasculitis, and then if you repeat after 2-3 months, which is recommended that you repeat a DS after 2-3 months, the occlusion or the aneurysm is actually gone, and they don't require, would just require a short burst of steroid and no maintenance dose of steroids. But except for that, most of them would require steroids. This is a cryoglobulic vasculitis in a patient of primary Sjogren's that I had, and she eventually died of the cryoglobulic vasculitis. We tried everything, high doses of steroids, plasma exchange, cyclophosphamide. Of course, at that time, rituximab had not yet come. So that is one thing that you could try in these patients. This was a BOOP interstitial reported case of Wegener's, and this lady also died despite giving her cyclophosphamide. She was lost to follow-up, and Wegener's, as you know, is notorious in relapsing. I came to know later that she is no more. But again, these are cases where you require high doses of steroids along with more immunosuppression even than steroids. Now just coming to a couple of slides of photographs on abuse, where steroids are abused. Epiphyseal dysplasias in children, especially some cases spondyloepiphyseal dysplasia or epiphyseal dysplasias, don't require any treatment, just reassurance to the parents that and steroids are abused. We have seen that in practice. In ankylosing spondylitis, syndesmophytes, bamboo, as I said, no role of steroids in these cases. Just they have to go for physiotherapy and NSAID therapy if the disease is still active. Subacute cutaneous lupus, this is taken from my textbook, but again can be very well managed with antimalarials, and but some of them would require steroids if they are still refractory to antimalarial therapy. Gottman's rash in patients of amyopathic dermatomyositis, whereas there is no real myositis, only skin rash. As I said, some of patients get ILD and interstitial disease, and then you have to use steroids. Otherwise, they don't require steroids. You just reassure them, and maybe you could use antimalarials for the skin rash if it's really cumbersome. Pulmonary hypertension in the case of scleroderma, as I said, no real hardcore evidence for the use of immunosuppression. In osteomalacia, miss these diagnoses sometimes, and you come to know, you mistakenly diagnosed as polymyalgia rheumatica, give steroids, and later on you do an X-ray and you see that it's actually loser zones. Hypermobility, the joint pains can be due to hypermobility, and you really have to diagnose that. They don't require any kind of treatment. Just go through a couple of cases to see how steroids are used. This is a 30-year-old lady with inflammatory polyarthritis for 2 months with a high swollen joint count and a high tender joint count. She is in functional class 4, which means that she can't take care of herself. Has a high ESR, she is seropositive and has a high anti-CCP antibody. She has 2 children and says that she has completed her family. Now, how would say these are the swollen joints and huge number of swollen joints and joints? How would one treat this patient? Which disease modifying drug you would use? I'm sure most of the rheumatology would agree that these are the patients who would be straight away on methotrexate, and there is no real need to go into the details. This is a case of early rheumatoid arthritis, and so one would use methotrexate. You could use 7.5, 10 milligram and bring it up to 15, 20, 25 milligrams, preferably parenteral injections in 1 or 2 months. And you combine it with low dose of prednisolone. These are cases of 7.5, 10 milligram, or some of us might use even higher doses like 40 milligram, bring it out to 30, 20 in a debulking form to ensure that they don't get erosions and the control of inflammation immediately. Which steroids you would use? Well, most of us would use simple prednisone, I think, because that is enough, and bring it down, and we know the absorption of prednisolone. What dose of prednisolone? As I said, there are 2 forms, the high dose and low dose. I personally use a low dose of prednisolone and bring it down, and whether to continue this steroids and how long to continue is a matter of debate, and there is ample evidence to suggest that if you use it for a couple of years or 3 years, that is really less likely to get erosions, these patients. But I found in practice that if you use that, it doesn't just go off, and these patients then continue for prednisone for forever and ever. You can't really take it off. So I would use it for 3 to 6 months and then take it off. But there are rheumatologists who use it for long term, and they have evidence to support that. It's a matter of individual choice. In our country, there are peculiar problems with the use of steroids, and that's a separate matter of discussion. Steroids in pregnancy, of course, you can use steroids in pregnancy. If this patient has not completed a family, you could use sulfasalazine, hydroxychloroquine, which are used, these modifying drugs in pregnancy, and you could use 5 milligrams, 10 milligrams prednisone is absolutely safe throughout pregnancy. There is no problem. As against that, you have a 30-year-old lady who presents with Raynaud's phenomena for 4 years. She has pitted scars, sclerodactyly, the Rodnan score, which is a skin thickening score on the hands, forearms, arms, even the abdomen, the chest, and the back. Everywhere there is a high score. She has developed recent hypertension, and her creatinine is 2. The urine shows 1+ protein. Now, would one use steroid in this case? Well, I've just purposefully written the Rodnan score here on the chest and the abdomen, because this is a case of diffuse scleroderma. As I said, that many of these patients would actually worsen with the use of steroids, and you would land up giving scleroderma renal crisis. As you could see that she's already in hypertension, probably is going into renal crisis. So that's why I've just written, and sometimes 1+ protein just confuses you. This is not glomerulonephritis, it is bland nephropathy. And so these are the pitted scars that are seen in these patients of scleroderma, that is sclerodactyly. And so I don't think that these cases warrant steroids, and one should actually not use it. This is a scleroderma renal crisis and diffuse scleroderma early. The management is giving AC inhibitors and controlling the hypertension simply. Now, if this patient has a PAH, well, I don't think there is still evidence to support the use of steroids, immunosuppression in PAH, but as against interstitial lung disease, yes. And if it's, as I said, a rapidly advancing ILD, then yes, of course, one would require steroids. And in such a case, one would combine it straight away with a steroid sparing drug, so that you can bring down the dose of steroids early. Myositis overlap, again, then one would use steroids. But of course, overlaps are more common with limited form than with diffuse form of scleroderma. So the take-home messages for the crowd today, I think the most important things are corticosteroids are very useful drugs if used in the correct doses for the correct duration in the correct way, as against the abuse of steroids, both in terms of real abuse and in terms of abuse which is made by us by telling the patients that they should not be used, and so patients don't tend to use it. It's actually these are very useful drugs, especially in our country where things like biologics are very costly. I mean, they're only for 1% of the population. There is little to choose between the different analogs as of now. I don't think there is hardcore evidence to support the use of either methylprednisolone or deflazacort as against simple prednisolone. The optimum doses, as I said, would depend on what condition you are treating. The adequate period will also depend on what duration you are treating, and the maintenance doses are normally continued for some time at least, and depending on what condition you are treating. In early rheumatoid arthritis, there is definite role of steroids in preventing erosions. Most of us would use it as bridge to a disease-modifying therapy. Intra-articular steroids are very useful, sparingly used by orthopedics. I don't know, that is what I have found in the part that I country, that they tend to avoid giving intra-articular steroids, whereas as rheumatologists we believe in giving intra-articular steroids as much as we can. Avoid as a solo therapy without disease-modifying drug. That is a misuse of steroids, I think, except for when the patient is planning pregnancy or something. Giving steroids alone as treatment to a patient early in disease is not right. One has to use a disease-modifying drug like methotrexate or cilozaparin. Major organ in lupus or organ thickening and in vasculitis, these are still the first line of treatment and are recommended and are used. As I said, ANA positivity would not result in a steroid use. It may not be right to do that. One has to really diagnose what condition it is. There is no convincing evidence for the use of steroids in scleroderma skin disease, in the axial disease of ankylosing spondylitis, or in soft tissue disorders, rheumatism disorders and fibromyalgia, or even in burnt out rheumatoid arthritis. The disease actually burnt out and the patient has ended up with deformities. The ESR has become low, and these are the patients who would actually go into extra-articular complications of rheumatoid but don't have rheumatoid disease activity in their joints. And even burnt out myositis where the contractures have already occurred. Use the minimum dose possible for the minimum duration, especially in children, because of the problem of growth retardation seen in children. And calcium and vitamin supplementation is needed in all patients that you are contemplating long-term use of steroids. And bisphosphonates, you don't require a BMD in a post-menopausal lady where you are going to continue prednisone for a long time. In a premenopausal lady, of course, the use of bisphosphonates would be guided by a BMD by DEXA scan. Thank you.